Hello, I'm John Bleacher, Chair of the Practice Committee of APSA. The committee is very excited to offer you our APSASode, which will include 2 abstracts of content that is related to practice committee interests and also a symposium related to coding headaches or challenging CPT codes. My vice chair is Tony Escobar, and I'll turn it over to you, Tony.
Thank you, John. My name is Tony Escobar, and I'd like to introduce our first abstract by Dr. Barry Newman from Providence Children's Health in Portland, Oregon, entitled Characteristics of Pediatric Surgical Practice in 2019, Survey of the American Pediatric Surgical Association membership for the Practice Committee. The abstract will immediately be discussed by Dr. David Yu from the Practice Committee. Thank you.
Doctors Bleacher, Escobar, and guests, I'd like to thank the Practice Committee and APSA for the opportunity to present the results of a survey of the APSA membership that was done on behalf of the Practice Committee regarding the characteristics of pediatric surgical practice in 2019. Recognizing that this is a time of dramatic changes in both medicine as well as in pediatric surgery, and given the general paucity of information regarding how pediatric surgery is currently practiced, it was felt that there was a critical need to better understand the situations and issues that affect the members in the practice of pediatric surgery today. Therefore, an internet-based survey of the membership was sent to over 1,100 members of APSA. A total of 39 questions sought information regarding demographics, practice characteristics, compensation methodology, and other issues. There were 277 responses for a response rate of 25%. The median age of respondents was 54, with a fairly even age distribution of pediatric surgeons across all deciles. However, the number of graduates is quite high in the most recent decade. That probably represents an increase in additional training programs, which has been described elsewhere. Whether this is or will become a problem will become more evident with time. Despite this concern, while many pediatric surgical practices believe they have enough surgeons at present, the majority do expect to recruit additional surgeons within the next 5 years. This may be due to current surgeons retiring or increasing volumes, but as the reasons for this are unclear, it may warrant additional study. Regarding gender, 73% were male, 26% respondents were female, and although the ratio of male to female surgeons was fairly high overall, when this ratio is examined compared to the years post-training, it appears to be evening out, suggesting that significant progress has been made in increasing female participation in the pediatric surgical workforce. However, regarding ethnic and racial makeup, 75% of the respondents were white, 11% Asian, 6% Hispanic or Latino, and 4% African American. Ethnic and racial disparities remain an issue. Although there is a relative paucity of Blacks in pediatric surgery compared to the general population, the percentage of various ethnic groups reasonably approximate those of various ethnic groups in the medical workforce. This can be seen by comparing our results with recent surveys done by the AAMC. I selected a survey published in 2010 for comparison here, as that was the time when the most recent graduates would have been selected or would have been selecting their specialties for training. More progress clearly needs to be made, though, on both fronts, both in pediatric surgery as well as in medicine in general. Regarding employment, the overwhelming majority of respondents had academic appointments. 51% were employed in an academic position. 41% were by a hospital or medical center, and only 8% were in private practice. 57% worked primarily at a children's hospital, 33% at a children's hospital within a hospital, and 6% at a community hospital. Income was mostly derived from salary with incentive, although 31% were employed with salary only, and only 8% were based solely on productivity alone. 7% worked partly or solely as locum tenens. Thus, it seems that the overwhelming majority of pediatric surgeons are currently in an employed situation, which matches the general movement from private practice into employment that's been noted around the country. This can be expected to have a substantial impact on how pediatric surgery will be practiced, as well as how pediatric surgeons will be managed going forward in the future. There is a trade-off for the security of a paycheck with the loss of autonomy to administrators. Time will tell if this benefit has been worth the cost. Of interest, the average group size was about 5 or 6 with a broad range of 1 to 26 surgeons. Many of these groups appear surprisingly large. Also noted was that the average hours worked per week was about 60, with most working between 50 and 80 hours. Cross-tabulations, interestingly, showed no significant differences by gender or by practice type. Everyone seems to be working hard. Of additional interest is the distribution of pediatric surgery. Pediatric surgeons, the vast majority now practice in locales with populations that greater than 1 million. If that threshold is lowered to 100,000, this includes nearly the entire workforce. There is clearly a problem with distribution of pediatric surgeons, and this is a problem that will have to be reckoned with, both for pediatric surgery as well as for medicine in general. Multiple solutions have been offered. However, addressing this problem will likely require some form of outreach by larger centers, as the trend in pediatric surgery clearly seems to be a movement pushing surgeons to larger academic centers and children's hospitals. 77% of respondents had hired a recent graduate, and of those, nearly 30% had some concern regarding their operative or management abilities for complex cases, and as many as 10% even had concerns about the graduate's ability to handle routine cases. This mirrors a concern that's been raised by various parties, noting the increased number of programs and the potential for dilution of the experience for training. In contrast, though, only 20% of the graduates themselves reported that they felt they needed additional mentoring or assistance for complex cases, and none felt they needed such assistance for routine cases. This is a disconnect that may not easily be resolved and might also be a consideration for future study. Regarding subspecialization, 40% of the practices had some form of subspecialization within their practice. While not yet a majority practice, there is a significant trend towards subspecialization, especially in academic practices, as opposed to non-academic practices where virtually everyone in the practice does everything. Another concern that had been raised was the issue of co-management of patients. The survey suggests a clear predisposition to manage surgical patients by the surgeon or by the pediatric surgical service. Only 9% of surgeons report that all children are co-managed, and the rest suggest a balance between complex medical needs and surgical needs that drive the decision. This is probably the best outcome to provide optimal care for the children taken care of by pediatric surgeons, as well as for training purposes if that enters into the equation. Speaking of which, nearly all pediatric surgeons are involved with teaching, whether compensated or not, and this can include students, residents, and surgical fellows. This probably follows the trend towards practice in academic centers. The addition of advanced practice providers such as PAs and nurse practitioners is also extremely widespread. While these practitioners are usually thought of as extenders, they are almost always employed by and subsidized by the hospitals where the surgeons practice, and occasionally they are hired by a wider group practice alone. Clinical revenue, however, is rarely the source of their salaries. At the time of the survey, the development of the Children's Surgery Verification Program was underway through the American College of Surgeons. While consideration of applying to the program was mixed, there was a clear disparity between those surgeons in academic programs and those in private or community settings. As a result, the success of that program may require additional impetus in order to gain traction. As a final note, when asked what concerns and issues were priorities to be addressed by APSA, there was a wide array of concerns documented. However, concerns around workforce issues and maintaining clinical experience, promoting quality of care for children, and surgeon wellness were at the top of the list. Advocacy, financial compensation, and career development were concerns for slightly lower numbers. However, there was still a broad array of other concerns which warrant following and paying attention to. Overall, the survey provides a reasonable baseline for future comparisons. A number of limitations need to be mentioned. First, while the response rate is sufficient, a higher response rate would have provided a more robust data set to draw conclusions. Next, this was not intended to be a manpower survey nor a salary survey. nor a demographic, nor any specific practice issue survey. In order to address any area in sufficient detail would have required the entire survey targeted to address those questions alone, and the decision was made to keep the study as broad-based and as inclusive as possible. Thus, as it was intended to be broad-based, it is our belief that this goal was largely achieved. In summary, a survey was done of Apsa membership, and a number of substantial findings emerged which have been discussed. Gender diversification may be starting to change, while ethnic diversification, though adequate for some subgroups, remains a problem for Blacks in medicine as well as in pediatric surgery. The overwhelming majority of pediatric surgeons are currently in an employed situation, which matches the movement from private practice into employment that has been noted around the country. There's a growing cohort working at children's hospitals or academic medical centers with a movement away from private practice. Subspecialization within practices is growing, but the majority of practice have not yet begun to do so. Growing concerns about the number and experience of recent trainees have been raised, and this could be a real issue judging by the experience of senior partners. There are many real issues of concern raised by respondents that will require more attention going forward. I thank you for the opportunity to present this information here, and I look forward to answering your questions as much as possible. Thank you very much.
Dr. Newman, thank you for that fantastic presentation. This survey and data are well-timed and speak to many of the issues currently being debated in pediatric surgery. Every slide could be an extensive discussion on its own and could be the focus of its own survey to more clearly understand the state of pediatric surgery practices. The nature of these data lends itself to speculation, but I think that speculation is what will lead us to gather more focused data to answer these questions more accurately. I had a few observations as I listened to your presentation. First, wellness was listed as one of the top concerns for pediatric surgeons going forward. However, more than half the surgeons are working 60 hours a week or more, and 75% say they have enough surgeons in their practice. There seems to be a disconnect between our reported concerns and our behavior. How do we decide how much and what kind of work is healthy, and how do we have this dialogue amongst ourselves and with our hospital administrations?
Well, first of all, thank you for your kind comments. They're appreciated. And yes, there's a lot of meat in this presentation. Regarding the question about wellness, we did not do a cross-tabulation for age or gender with the concerns regarding wellness, although that might have been interesting to see if younger surgeons had a greater concern for that compared to those, say, trained longer ago. It seems that everyone believes in wellness these days, but surgeons in general, and especially high-power competitive surgeons, which you kind of have to be to get accepted and to finish training in pediatric surgery, may also tend towards longer hours. However, maybe it is the working 60 to 80-hour work weeks is why people are concerned with wellness, but I don't have a good answer for that.
Recently, there's been a movement and a narrative in pediatric surgery that practices are moving towards significant subspecialization. Yet, even in this group of mostly academic surgeons polled, 60% of them say they work in an area where there's a pediatric surgery fellowship. Only around 40% report having subspecialization in their practices. Also, the most common practice size in this group of polled surgeons was 4. It seems like specialization is harder in smaller groups. So do we need to revisit this larger narrative and have a goal of subspecialization only in the few larger centers?
That's a great question. This is an area of growing concern, and it's one that does not really have a good answer as of yet. But perhaps a better question might be, is how much subspecialization is necessary or even good? In some private conversations I've had over the past several years, some groups have now developed what they call an expert program, where 1 or 2 members become the experts in a particular disease or abnormality, and they are become available as intragroup resources. So in other words, each member can still manage their own patient, but the expertise is available for assistance as needed. And maybe something like that becomes a better model. Thank you.
And although as a specialty, it seems recently we've done a better job of recruiting women. And as you pointed out from an ethnic standpoint, the makeup of pediatric surgery mirrors medicine as a whole. As a tight-knit specialty, how can we do more to encourage and recruit more minority applicants?
That's also a really good question, and it's certainly top of mind currently. Given the current diversity of the medical pool, I'm not sure how we can entice more minority applicants into pediatric surgery at this time. I believe that the ultimate solution is going to attract more minorities into pre-med and then medical school, and that will enable an increase in the overall pool of potential applicants for pediatric surgery and make it a lot easier to expand that availability.
And then lastly, at a time where all our inboxes are bursting with requests to fill out one survey or another, if you could pick one area of this data that you'd want to look at more closely, which one would it be and why?
That's another really great question, and one that's really hard to answer. There are so many questions that were only partly addressed in this survey, and there were many that were not asked. In order to make this survey even manageable, we needed to omit many questions that we would have liked to ask or even really needed to ask. Having an understanding of pediatric surgical practice in these challenging times is a critical undertaking and one that is not well developed, hence the need for this survey. It was our hope that, supported by the board, that this would become a biennial survey, which would give us good information, not only as a one-shot deal, but as a view over time. If this were administered regularly, it would be possible to add some questions and pair others as needed, but still maintain the continuity of the information. Hopefully that can become a reality. I thank you for your questions and appreciate your thoughts. It was great.
Thank you, Dr. Newman, and thank you again for that wonderful presentation.
The second abstract to be presented is entitled Employment Search Experience of Recent Pediatric Surgical Fellowship Graduates, an APSA survey. It will be presented by Dr. Abigail Martin at Nemours AI DuPont Hospital for Children and Sidney Kimmel Medical College of Thomas Jefferson University. Immediately following Dr. Martin's presentation, Dr. Aaron Teeple will give a discussion.
The APSA Workforce Committee would like to thank you for giving us this opportunity to present our work on employment search experience of recent pediatric surgical fellowship graduates. We have no disclosures. The ultimate goal of the Right Child, Right Surgeon initiative is to help define a framework that allows all children to have access to high-quality pediatric surgical care. One area that has received attention is the geographic concentration of trained pediatric surgeons in urban environments and the corresponding paucity of trained pediatric surgeons in rural areas. In addition, the pediatric population in the United States has remained relatively stable, while the number of pediatric surgery fellowships has increased over time, leading to dilution of experience at the individual surgeon level. The reasons underlying these trends are multifactorial, but they include the interrelated themes of surgical education, maintaining competency for treating rare conditions, subspecialization within general pediatric surgery, and the availability of resources in different environments. Our committee recognizes that the younger members of our specialty will be most affected by any changes in training or employment opportunities. We sought to better understand the experiences and motivations of recent pediatric surgery fellowship graduates entering the workforce through an online survey sent to APSA members identified as having completed training over the previous 10 years. We had a 32% response rate. The distribution of respondents over the 10-year period was fairly uniform, with the highest from 2015 and the least from 2011. In general, the majority of respondents were interviewed for 3 to 5 distinct positions, although there were some outliers. Using a Likert scale, we asked respondents how important certain factors were in choosing a position. The most important factor was geography, with 89% saying it was important or very important. In the comments about other factors, there were mentions of military obligations, balancing the needs of a spouse's career, the opportunity to practice within a certain subspecialty, and the personal relationships with potential partners. When we asked participants to identify the top 3 most important factors, geography again proved to be the most significant. Available mentorship and compensation were also important. Interestingly, schedule flexibility and call requirements, which we thought would be indicators of the desire to maintain work-life balance were not amongst the most important considerations for respondents. Now let's take a closer look at what those employment positions looked like. For these questions, we asked respondents to only comment on their first employment position after training. 77% described their job as academic. A similar proportion, 78%, described the location as metropolitan or urban. We asked them to describe the hospital in which they perform the majority of their work. 55% report working in a freestanding children's hospital. Less than 3% report working mainly out of a community or adult hospital. Recalling that 3/4 reported working in an academic setting, an even higher percentage, 94%, help train general surgery residents. 49% are faculty members of a pediatric surgery fellowship program. 91% reported having completed dedicated research years during their training, and 62% perform research within their first employment position. We asked survey participants to break down how they spend their time in their job. As expected, all had some patient care responsibilities, and as mentioned earlier, most participate in some form of resident training. Most also have some administrative duties, and many perform clinical or outcomes research. Only 7% report participating in basic science research. We did not ask respondents to report whether the research they performed during training was basic science or outcomes research, so we can't directly compare this to their employment experience. 26 respondents had completed another advanced degree prior to completing their pediatric surgery fellowship, mostly Masters of Public Health. 26 respondents also reported having completed another clinical fellowship besides pediatric surgery, the most common fellowship being trauma critical care. However, when we asked whether they still practice within this second area of specialization, only 14 of the 26 respondents answered yes. Whether that was an intentional decision by those surgeons is unclear, but it potentially represents lost intellectual capital for our field. When we asked survey participants to indicate their level of satisfaction using a Likert scale, a large majority responded agree or strongly agree to these statements. In summary, most respondents were satisfied with the position they eventually accepted. That has led our committee to interpret the trends that have been presented here to be the result of intentional choices by those recent graduates. We wanted to find out what all of the survey participants thought about subspecialization. The results were mixed, with only 44% responding that they do support subspecialization within the field of general pediatric surgery. This is a similar percentage to surveys of the entire APSA membership. When asked for comments, those in favor mentioned that specialization was important, especially for certain rare conditions to improve experience and outcomes. Others mentioned the idea of establishing local content experts who could be a resource, but who would double scrub with their partners on these procedures to ensure that others in the group also gained some exposure to these cases. Commenters who did not support subspecialization spoke about the effect on other surgeons by diluting their exposure or creating unfair advantages for academic centers. They also mentioned that this could lead to regionalization of care and place burdens on patients and families. There was also not uniformity in comments concerning which areas should be considered subspecialties. Transplant, hepatobiliary, oncology, endocrine, colorectal, and trauma all received some mentions. In order to investigate perceptions concerning potential dilution of experience, we asked participants to give their opinions about the number of pediatric surgeons in their practice region who perform certain procedures as too low, just about right, or too high. We considered cases like CASIs and PSARPs as specialized index cases. Emergent neonatal surgery specifically referred to necrotizing enterocolitis and spontaneous intestinal perforation. For all types of cases, the majority of respondents said that the number of surgeons was just about right, implying that at least for these graduates, they don't interpret their cities or areas as having an overly saturated market in terms of the numbers of pediatric surgeons. The type of cases for which the most respondents said that there were too many surgeons was the index level cases. This makes sense intuitively, since the index level cases are usually the type of procedures that drew most of us to pediatric surgery in the first place. Of course, these are self-reported responses, and we do not have objective data with which to compare these subjective opinions. In reference to index level cases, we wanted to investigate respondents' opinions about the minimum numbers of cases needed to maintain competence. The yellow and blue bars represent the percentage of respondents who replied greater than 2 or greater than 3 cases per year. Interestingly, based on the responses, 2/3 felt that this level of exposure was necessary for performing PSARPs, but only 1/3 felt that way about Kasai portoenterostomies. These responses recalled the results of a study of one-year case logs submitted by applicants for APSA membership published by Baer and colleagues, in which the median number of procedures actually performed over a one-year period was 3 for anorectal malformations versus 1 for tracheoesophageal fistula and 0 for Kasai portoenterostomy. The observation that opinions about what is required to maintain competency reflect studies of actual operative experience may simply be due to a bias that individuals want to view themselves as proficient. To explore opinions about potential alternate training approaches as a method to address underserved populations, we asked respondents whether they would support such programs. We based these potential pathways on descriptions Dr. Fallett presented during her APSA presidential address. The idea of an acute care pediatric surgeon to include some specialized pediatric surgery cases such as pyloromyotomies, but no index level cases, was only supported by half of the respondents. The idea of a general surgeon with pediatric expertise who could perform cases such as appendectomies and cholecystectomies in school-age and adolescent populations had more support at 67%. We also asked how long such training programs should last, with most respondents answering 6 months to 1 year. In conclusion, most of the respondents to this survey were happy with the employment they found after training. Support for concepts such as subspecialization and alternate training programs was mixed. But what does this ultimately mean for our specialty? Based on the current survey, a large proportion of recent graduates practice in environments that mirror where they have spent the previous 7+ years training, and this is likely by design. Thus, if we are to address disparities in the delivery of pediatric surgical care, we should not rely solely on the choices of individual trainees and graduates to solve this problem. If we want to increase access to care, we have to find innovative ways to bring surgeons to the populations that need them. Support for such initiatives is mixed, so we still have work to do in order for our community to come to consensus about how to achieve these goals. We owe thanks to many people who helped in the completion of this survey. This is only a small part of the Right Child, Right Surgeon initiative. Our committee hopes to continue to engage all APSA members on this topic. Thank you for your time and attention.
Thank you, Dr. Martin, for that excellent talk, employment search experience of recent pediatric surgical fellowship graduates and APSA survey. Can you take a few moments to describe to those who are unfamiliar the Right Child, Right Surgeon initiative?
Of course. At its simplest form, it's essentially an initiative to look at the issues that affect how pediatric patients have access to pediatric surgical care. Its goal is to try to ensure that all pediatric patients throughout our country have access to the appropriate surgeon with the appropriate training, recognizing that there are currently disparities in where the patients are located versus where the practitioners who are trained pediatric surgeons are located.
Okay. Your talk initially discussed graduates of PSurge Fellowship from the last 10 years in their first jobs. In general, the majority stayed in academic and metropolitan areas, with the most important factors in their job search being geography, mentorship, and compensation. When we expanded pediatric surgery fellowship training spots, maybe that wasn't the intention, as we recognize that there's underserved areas in the country, for, as you just said, for pediatric surgeons. And instead of distributing to these underserved areas, we perhaps have concentrated more on these coveted metropolitan academic programs. And with this came the questions of maintaining competency as well as continuing to serve these underserved areas. So then you expanded your or included in your survey questions regarding these two factors. So how are we going to maintain competency if those concentrated areas become more populous with pediatric surgeons? And how do we now envision getting high quality pediatric surgical care out to these underserved areas? So the second question I have for you is regarding maintaining expertise in these lesser procedures that happen less frequently. And so survey respondents thought that 2 to 3 procedures per year were necessary to remain competent in most procedures, with the exception of Kasai's, which was 1 to 2. Can you talk a little bit about that? Do you think that's a reflection of the fact that these are the population incidence of biliary atresia, or do you think that perhaps this is a reflection of existent subspecialization in this area?
I think it's probably due to a lot of factors. One thing we do know is that there are studies that have looked at the operative experience of graduating fellows, as well as the operative experience of recent graduates when they apply for their pediatric boards. And in all of those studies, there is always a subset of the surgeons who have done no Kasai's at all in the time period that they have looked at. And the median and mean of those studies is quite low. Sometimes it's 0, sometimes it's just below 1. So this is clearly a very rare procedure. And so most surgeons are not going to see a large volume of that. In terms of the issue of subspecialization, I think local pediatric surgical centers have approached the problem in different ways. I think there are some centers that have access to expertise with pediatric surgeons who also have experience in complex hepatobiliary surgery and transplant surgery. There are other programs where there is a single designated surgeon amongst the group that subspecializes and does all, if not most, of the Kasai procedures there. But I think there's also a segment of the population that doesn't have access or easy access to that expertise. And so those Kasai procedures may be done by someone who doesn't have as much competency or experience. And in answering the survey saying that fewer numbers of cases are required, some of that may be what they were exposed to during their training or what they're exposed to in their current practice situation. But it may also reflect the fact that no one likes to think that we aren't experienced and capable of dealing with these procedures. And so it may reflect their own biases based on their own personal experience. I think it's, unfortunately, I don't think we're going to be able to figure out the exact cause based on the current survey, but I think it's probably multifactorial.
Yeah. And lastly, in just our last minute here, the proposed solutions to extend pediatric surgical care to underserved areas were also included in your survey. Did you get a sense of why the solutions, including an ACS tract to pediatric surgery, as well as some further pediatric surgical training for general surgeons, received only about a 50 to 60% support rate?
Based on the comment, we did have some free comments about that question. And based on the responses, the survey respondents who were in favor of this potential application is that it would expand access to pediatric patients, which again gets back to the goal of the Right Child Right Surgeon initiative. The respondents who were not in support of these training paradigms were concerned about things that, would this dilute experience even further amongst the current pediatric surgeons? How would that affect current pediatric surgeons in practice? Would it take away their own base for getting patient referrals? There was a concern that for trainees that it would be seen as a watered down pediatric surgical track, and that would not be very attractive to high quality applicants. So again, I think it's very multifactorial, but those were the most commonly reported reasons for why they were not in support of this.
Well, I think it's just tip of the iceberg.
Definitely.
So thank you for spending some time with us and answering some questions. And thank you so much for your excellent talk.
Thank you. I appreciate you taking the time today.
It is my honor to introduce the joint APSA Symposium being presented by Mariah Bowden and being moderated by Evan Kokoska, Kevin Moriarty, Nick Fiore, and Richard Weiss. The topic of the symposium is strategies to optimize the successful reimbursement of unlisted CPT codes. The symposium specializes in looking at specific pediatric surgical procedures that are different from our general surgery colleagues, and I hope that you will find this useful for your practice.
Hi, my name is Evan Kokoska from Indiana, and a select group of us amongst the practice committee has been working on coding conundrums. And we've been working with Mariah Bowden from Oregon, who represents the American Pediatric Surgical Managers Association, or APSMA. And we have found her to be fantastic to work with and help sort out some of these coding conundrums.
Hi, my name is Mariah Bowden. I'm the Division Director of Pediatric Surgery at Oregon Health and Science University. I also served as APSMA President from 2018 to 2020. The American Pediatric Surgery Managers Association, or APSMA, is APSA's affiliated organization for managers. Our membership is made up of hospital-owned, academic, and private practice administrators. APSMA is a knowledge resource for benchmarking data, contract negotiation, revenue cycle management, billing and coding education specific to pediatric surgery, and much more. As you already know, managers are significant collaborators and contributors to the success of your pediatric surgical practices. We would appreciate your help recruiting your administrator or practice manager to APSMA. The annual membership dues, only $350, will directly benefit your practice and the families you serve. One mission of the APSA Practice Committee is to offer education and assistance to the APSA membership about issues involving billing and coding. So the Practice Committee reached out to the APSMA Executive Board to partner on this presentation. In this APSASode, we will discuss important modifiers that you should be familiar with in order to optimize reimbursement, and a number of procedures that are notoriously difficult to code or receive reimbursement for in pediatric surgery. Our goal today is to offer best practices, knowing that they may not be uniformly successful. Reimbursement can vary payer by payer or state by state. As the basis of this presentation, we solicited guidance from the ACS Coding Hotline. As a reminder, each year, ACS fellows can receive 5 free consultations through the ACS Coding Hotline. We also surveyed several institutions represented in APSMA. Each of these hospitals has a professional services coding department and also a compliance department guiding their billing and coding practices. Having said that, please remember to run any changes in your coding practice by your compliance department. What is the difference between a co-surgeon and an assistant? An assistant at surgery, or a first assist, is considered medically necessary when the complexity of the operation necessitates that the primary surgeon have additional skilled operative assistance from another licensed professional, basically another set of experienced hands. An assistant is usually reimbursed 16 to 20% of the contracted rate, depending on the payer. Medicare allows 16% of the usual surgical allowance for this service. But in Oregon, we're seeing Modifier 82 payable at 20% of the contracted rate for most plans. When there's a first assist in a case, only one op note is written, preferably by the primary surgeon. If you are at a teaching institution, documentation must also state that no qualified resident was available to first assist. Remember, this op note is your supporting documentation for the Modifier 82 claim. Specify in the body of your op note what the assistant actually did, such as retraction, exposure, assisting in anastomosis, decision-making. Payers will often deny Modifier 82 claims if there's no accounting by the surgeon for what was actually performed by the assistant. It's also a good idea to describe in the indications paragraph why there was a need for an assistant. Your supporting documentation must describe medical necessity for the assistant. Your billing team should then submit the op note with the claim. Remember that once an op note is signed by the surgeon, it becomes a legal document and cannot be altered. For a first assist claim denied for lack of documentation, you can always go back and add an addendum to the op report, and the claim can then be resubmitted. Modifier 62 is intended for use only when two surgeons work together as primary surgeons, performing distinct parts of a single reportable procedure. Co-surgery can refer to two surgeons, each in a different specialty, being required to perform a specific procedure, or co-surgery can also refer to two surgeons performing the different parts of a procedure simultaneously. In this case, medical necessity for having two surgeons from the same specialty must very clearly be documented. For both surgeons to receive appropriate reimbursement, they must not be assisting each other, but performing distinct and separate parts of the same procedure. Essentially, a co-surgery is when two surgeons split one reportable CPT code. Co-surgeries require an op note from each co-surgeon describing their portions of the surgery. Both surgeons would bill the procedure with modifier 62. The co-surgeon is reimbursed 62% of the contracted rate. So to recap, an assistant helps the primary surgeon perform a surgery, whereas a co-surgeon independently performs one or more aspects described in a CPT code. Another modifier that you should be familiar with, modifier 63, indicates the procedure was performed on a patient weighing less than 4 kilos. Some payers will reimburse an additional 20% of the contracted rate for this modifier. But it's important to note that procedure codes already including neonate or infant in the code description are not eligible for modifier 63. The reimbursement rate for these codes already reflects the additional work associated with the age and size of the patient. If you ever want to see a summary of all CPT codes exempt from modifier 63, these can be found in Appendix F of the CPT code book. Now, modifiers 63 and 22 should not be billed together on the same CPT code. If the patient weighs less than 4 kilos, default to modifier 63. But if modifier 22 is one that you should be familiar with, the values assigned to CPT codes assume an average service. Modifier 22 can be used to seek additional reimbursement when the provider's work is substantially greater than typically required in relation to other procedures of the same type. Difficulty alone does not justify adding modifier 22. It should only be used with procedures for which the provider spent significant extra time, resources, or mental energy in order to complete. So only rare outlying cases, those far beyond the average difficulty, call for modifier 22. As always, support for the claims rest on strength and detail of your documentation. The op note must describe why the surgery was unusually difficult or time-consuming and what you did to resolve the unusual issues. To help facilitate payment of these claims, consider including a separate paragraph titled Modifier 22 Statement in your op note to call out the extenuating circumstances that differentiated the surgery from others of the same type. And in this statement, be sure to also discuss the amount of time you spent addressing those extenuating circumstances beyond what is normally expected for the procedure. It's not enough to simply note the total time spent addressing the complication or extenuating circumstances. Don't use general statements like surgery took an extra 2 hours, or this was a difficult surgery, or surgery for an obese patient. While these all may be true, these comments lack specific details identifying why the procedure was beyond the normal difficulties that could be encountered with the procedure. Some payers will reimburse an additional 20 to 30% of the contracted rate for modifier 22. But be prepared for payers to pay very close attention to your modifier 22 claims. Using this modifier on a routine basis will most certainly cause scrutiny of submitted claims and may result in an audit. Unlisted CPT codes. When should you use them? You should not report a CPT code for a specific procedure if it does not accurately describe all parts of the service performed. Don't select a CPT code that merely approximates the service provided. If no such specific code exists, then report the service using the most appropriate unlisted procedure code. Using unlisted codes can be a hassle in terms of billing, but it helps with data tracking to know which procedures are being performed under unlisted codes and which procedures need specific codes developed to represent them. When considering whether to use an unlisted code, be sure to determine if the claim might be better represented using a specific procedure code with a modifier attached. Also, remember that laparoscopic assisted procedures can be billed with open codes. If any part of the procedure is open under direct visualization, you can report the open code. If it's a laparoscopic only approach with no part of the procedure performed under direct visualization, then an unlisted code must be used if there's no lap code equivalent. Submitting an open code for a laparoscopic procedure is not an innocent billing mistake. This is considered billing for a service not rendered and a service that is not supported by the patient's medical record. And you definitely don't want to knowingly submit false claims. That would fall under the False Claims Act. When billing unlisted codes, payers require a comparison code and comparison value also be submitted, along with your op notice supporting documentation. To facilitate payment for unlisted codes, include the operative report and provide a comparison code. This comparison code should be the most like code that you can find. We use this to provide a suggested fee by comparing the procedure to the type of work required for a similar procedure. So select a CPT code with a similar work value. Look for indicators like same approach, same technique, number of steps, etc. There is not a code for thoracoscopic diaphragmatic hernia repair. So you'll need to report the unlisted code 39599. Then use the open code as your comparison code. Because there is also no laparoscopic code for a lap pyloromyotomy, you must use the unlisted code. You can use the open pyloromyotomy code as your most like code for comparison. For thoracoscopic esophageal or tracheal esophageal atresia repair, the unlisted code should be used 43499. You can use 43314 for value comparison. There is not a code for a lap detorsion of ovary either, so the unlisted code should be reported. Here I've suggested 3 different comparison code options. At OHSU, we're currently using 44050 as our like code in both pediatric surgery and OB-GYN. A question that pops up in our APSMA discussion forum occasionally is, do you use an unlisted code to bill a ruptured lap appy? There's some gray area here. Some people are and some people are not. This is not clear cut. There is a standard lap appy CPT code 44970. Then we tell the payer it was ruptured with the diagnosis code. A modifier 22 can also be added when the surgery is documented as being substantially more complex than the standard lap appy. For instance, if the appendix is really stuck and it takes you a significant amount of time and effort to mobilize it, you might consider modifier 22. The ACS coding hotline did suggest an unlisted code as an option for ruptured lap appy, but it seems compliance officers at many institutions do not agree with this. The exception would be if the insurance company doesn't allow you to bill 44970 with modifier 22. If a payer will not accept the standard lap appy code with the 22 modifier, then you may consider billing the unlisted code. Then using 44970 with modifier 22 as the comparison code and price. Can G-tube placement be billed with a lap Nissen? No, these are bundled. Per the AAPC, any designated separate procedure is bundled when provided with another service or procedure in the same anatomical location. This means that the work for placing the G-tube is already included in the Nissen code and should not be reported separately. When you see separate procedure noted in a CPT code's description, this indicates that it is not usually reportable with other services, that the code is usually only reportable when performed alone. Drainage and peritoneal lavage in a neonate with perfed bowel. If the abdominal washout and drain placement is performed after the patient has had surgery for the perfed bowel, you can use code 35840. Or if the patient is not post-surgery, then code 49020 for drainage of peritoneal abscess or localized peritonitis may be appropriate. Both of these codes would be reported with modifier 63 when performing these procedures on a neonate. Laparoscopic duodenal atresia repair would require unlisted code 44238. In this case, you would use one of the open codes listed here as your comparison code. Coding open or lap-assisted duodenal atresia repair depends on how the procedure is performed. If resecting intestine, then consider 44126 or 44127. However, if not resecting the small intestine as described in these codes, the ACS coding hotline recommends CPT code 44130 instead. Lap pull-through is another tough one. For laparoscopic endorectal pull-through for the imperforate anus, the ACS recommends using unlisted code 45499, and you would use one of the open codes for comparison. But remember that if any part of the procedure is done open under direct visualization, these open codes are perfectly acceptable. However, some of the hospitals surveyed by APSMA are billing 45397, then just indicating whether a lap pull-through is for imperforate anus or Hirschsprung's with appropriate diagnosis code. For a lap-assisted pull-through for Hirschsprung's, report the open code 45120. If it's performed via a laparoscopic-only approach, then the unlisted code should be used since there's no lap code equivalent. The ACS coding hotline also advised that 45397 could also be reported for this procedure. And if a reservoir is not created, modifier 52 could be added, indicating decreased services. And again, some of the hospitals surveyed are billing 45397 for Hirschsprung's as well. Coding a pilonidal sinusectomy is based on whether excision of cyst is simple, extensive, or complicated. A simple excision is closed in only one layer. For the Bascom procedure, codes 11771 or 11772 would be appropriate depending on the documentation, since the operation involves removing the infected tissue, which is often more extensive than it appears on the surface. For the Gibbs procedure, 11772 would be appropriate because the code description specifies that the wound may be left open to heal by granulation. Billing a NUS procedure when more than one bar is placed. There is not an additional code for more than one pectus bar. The CPT remains the same regardless of how many bars are used. The code should be only reported once, regardless of one or two bars being inserted. However, the code descriptions for 21742 and 21743 do say specifically that usually only one bar is placed. So modifier 22 is appropriate if significant time and effort are documented. The procedure would need to be documented as being significantly more complex due to the patient's age or Haller index. And remember to include the amount of time spent above and beyond the average one bar NUS procedure. Similarly, there's not an additional code for removing more than one bar. The CPT remains the same regardless of how many bars you remove, but modifier 22 may be appropriate if significant additional time and effort are documented. Again, you would need to document that the work required was substantially greater than typically required for a 1 bar NUS bar removal. To continue this conversation, we've created a thread on the APSA discussion forum titled 2021 APSASode, Optimizing Successful Reimbursement of Notoriously Difficult to Code Procedures. If you have further questions, or if you're watching this presentation at a later date, please have your manager or coder post in our APSMA Billing and Coding discussion forum at apsma.net. On behalf of APSMA, it's been our pleasure to partner with APSA to produce this APSASode, and we look forward to future collaboration with APSA.
Hi, Evan Kokoska back, and thank you for an outstanding talk, Mariah. I know it took you a lot of time to do that and represent your group. Thank you so much. So with me on the panel to discuss some of these topics tonight is Nick Fiore from Las Vegas, Kevin Moriarty from Bay State, and Richard Weiss from Hartford, Connecticut. So take it away, guys. I think one of the biggest take-home messages I got from the talk was that clearly there's a couple ways to skin a cat, as evidenced by the concept that the American College of Surgeons hotline in and of themselves had differing answers and differing recommendations with regard to coding the same case. So what are your thoughts, Nick?
So yeah, definitely that was the case, and it was a little bit confusing, but I think we've managed to get a lot of clarity. Just to give a little context to this, I'd like to refer to Dr. Weiss because he is our representative for the RUC. Dr. Weiss, if you would tell us a little bit about yourself, what the RUC is, and the history of the coding changes that have occurred, say, in the last 20 years or so. Thank you.
Sure. I'm one of the pediatric surgeons in Hartford, Connecticut at Connecticut Children's Medical Center, and I've been APSA's RUC advisor for about 3 years now. There are a handful of other APSA members who have filled this role, some of whom for a lot longer than me, who may know even more about this. But the RUC stands for the Relative Value Update Committee. It is a committee of the American Medical Association, and it is the committee that is charged with providing the RVUs that we all live with, whether you're in private practice or employed, for the past 20 to 30 years, since the mid-1990s, I believe. Recommendations of this committee go to the Center for Medicare and Medicaid, or CMS, which is the federal government's organization that guides Medicare. Why do we care about Medicare? Because all the insurance companies will use the recommendations published by CMS to give the RVUs for all the different things that we do, whether it's an evaluation management code or a procedure code. This committee meets 3 times a year and basically goes over any codes that get referred to it by either CMS or by the CPT editorial committee, another committee of the AMA, for valuation. Some of these are new codes. Most of them are revaluing old codes. And one of the problems is that this is a budget neutral process by the time it gets to CMS. So if all the codes go up in value, CMS lowers the conversion factor when they pay out what they reimburse providers. We have been asked probably multiple times in the past, why don't we have codes for a whole variety of different things that we do, many of which are laparoscopic? And it's really a question of be careful what you ask for. The process is pretty objective, but there's also some politics behind it and knowing how the system works out. So APSA has been a beneficiary of this process many years ago with a whole bunch of newborn codes. And we are fairly leery about reopening the box in many of these codes. There certainly have been codes that have been resubmitted for revaluation by other societies, and you take your chances. Sometimes the RVU goes up, sometimes it stays the same, and not infrequently it goes down.
So then with the changes we've had in the past, and I think it's kind of 20 years ago with congenital diaphragmatic hernia and gastroschisis, I think it's really important to emphasize that those included postoperative care. So the surgeon needs to remain involved in the care of those babies and document that every day, probably until discharge, in order to take full advantage of it and to represent the way we're intended to be represented. Is that correct?
Yes, there is a little bit of a new idea coming from CMS to get rid of the 90-day global period and change it to a 0-day global. That could be fraught with problems for pediatric surgeons, or it may be advantageous to some pediatric surgeons. For now, I think in the best interest of APSA, it's best to sit tight.
Well, thank you, Richard. Any other questions you have, Kevin, or thoughts?
Yeah, so one thought is, as far as if you do a laparoscopic appendectomy, single incision, say through a existing umbilical hernia, you use a wound protector, and then you mobilize the appendix and then do the appendectomy extracorporeally, ligate the mesentery and do essentially an open appendectomy. The question is, can you bill for the umbilical hernia? And the answer is no. But the question is, can you bill for a open appendectomy versus a laparoscopic appendectomy? What's your thoughts on that? I know what this ACS hotline said.
They probably
I think one of the
no.
encouraging things that Mariah said was that for the lap suave pull-throughs, as well as the lap and perforated anus repairs, that if any part of the operation is open, according to the ACS hotline, that we can legitimately code the open code.
So that's what I thought, and I worked with my coders, and they agree with the ACS hotline is no, it's laparoscopic, not open appendectomy.
I think the RVU is the same for an open versus a laparoscopic. The big issue has been a laparoscopic appendectomy for perforated appendicitis.
Correct. And then what we do is use a modifier 22 and document why it's more difficult to do the perforated appendicitis case laparoscopically.
Fairly extensive documentation.
Yeah, and those patients usually spend a lot more than one day in the hospital, so it's also the postoperative care.
And then your coders, when they send out for the code, the 44970, they do send additional documentation right along with the first effort to send out the coding for billing purposes. Is that correct?
Yes, they do. That is correct.
Richard, I was excited that one of the options for a perforated appendectomy laparoscopically was using the unlisted appendectomy code, but my compliance department at my institution wouldn't buy it, which is unfortunate because that's a difference of 5 RVUs. You do 50 to 100 perforated appies a year, it adds up.
That is the same advice that our compliance people gave us. And I think that's the recommendation of the American College of Surgeons as well. But you're absolutely correct, it's less RVUs. But both we and especially the ACS is very leery to open a can of worms and submit a new code for laparoscopic removal of a perforated appendicitis.
Totally understand. I think another encouragement, there have to be some positives in all this, is the Gibbs procedure seems to do pretty well with regard to excision of pilonidal tracts and such, at least according to the ACS hotline.
Evan, I just wanted to ask you about duodenal atresia. I know that's one of your favorite codes. In terms of really, there isn't one for duodenal atresia. There isn't even an open code that's appropriate, and we're instructed that we shouldn't use the closest code. That's not kosher to do that. So in the case of duodenal atresia, really, what are our choices, especially if you do it laparoscopically? There's a 44126, which is an enterectomy and anastomosis for atresia, and it seems like that's the closest one. Or a small intestine anastomosis. I guess those are other choices, if done open. And then laparoscopically, I guess it has to be unlisted. What are your thoughts on that?
I think it's brutal. I think we try to put through 44126, but one of the recommendations was to use that code with a modifier to make it less valuable. And we all know that a duodenal atresia can be way more challenging than a jejunal atresia with resection. So I'm at a loss as the right way to go about it. Any y'all have any better suggestions?
No, I agree with you.
And I agree as well.
As far as the NUS operation, we use the code 21743, and some of these older children require 2, sometimes 3 bars, and it does add significant to the procedure. And what we just do is increase the modifier for a 22 and document why and how much longer it takes to do the procedure.
And how do you guys do the drainage for the SIP, the spontaneous intestinal perforation that the micropreemie gets? We do a 49020 according to Mariah. That's acceptable to do that, the drainage of peritoneal abscess. Are there any other options, or how do you approach that?
And then I would add a modifier 63 for the weight of the child, and just you have to put that in your note.
Agree, that's what I'd go along with.
The use of modifiers is interesting and really depends on insurance companies as to whether they reimburse for modifiers or whether they don't. Medicaid, at least here, does not. If you are collecting RVUs from your employer, then you have to negotiate what the RVU is going to be increased or decreased for each of the different modifiers.
Yeah, I don't think many people are going to use a modifier to decrease the amount of work that they're doing. So most of the time, what we negotiate with our physician billing office is what a modifier 22 is worth and why. And they do submit it, I think, with variable response depending on the insurance company. But our currency at work is work RVUs because we're an employed model, and that's how we're measured.
Yes, we're in private practice, Kevin, and we basically had initial experience with modifiers, and it required an incredible amount of documentation. It resulted in a long conversation. Ultimately, it didn't even pay off. It wasn't even worth all of the effort to do it. So we've, in the private practice setting with insurance companies, we really haven't had much success with the modifiers at all.
Thank you for watching this episode, and we hope it was educational for you and your practice.
Thank you for watching the Practice Committee APSASode on coding issues, and the Practice Committee hopes that you enjoyed our symposium on the coding issues presented by APSMA and the APSA Practice Committee. We thought it would be of great interest to many members of APSA, as it gives information that is useful to our practices. I would like to encourage all of you to see that your practice managers are participants and members of APSMA because they are integral to the work that we do. And if they are not members, please encourage them to join. Thank you very much and have a good evening.
Thank you.